against infection or disease and can take several weeks. That means those vaccinated should continue to take measures to protect themselves by avoiding close contact, including sex, with others who have or are at risk of having monkeypox. There are also challenges with the availability of vaccines. There are about 16 million doses of MVA-BN globally. Most are in bulk form, meaning they will take several months to fill and finish into vials that are ready to use. Several countries with monkeypox cases have secured supplies of the MVA-BN vaccine, and WHO is in contact with other countries to understand their supply needs. WHO urges countries with smallpox vaccines to share them with countries that don't. We must ensure equitable access to vaccines for all individuals and communities affected by monkeypox in all countries, in all regions. While vaccines will be an important tool, surveillance, diagnosis, and risk reduction remain central to preventing transmission and stopping this outbreak. Meanwhile, although the COVID-19 pandemic is far from over, we're now in a very different situation to where we were a year ago, and we have learned a number of important lessons. One of the most important is that the most effective way to save lives, protect health systems, and reopen societies and economies is to vaccinate the right groups first. Even in some countries that have reached 70% vaccination coverage, if significant numbers of health workers, older people, and other at-risk groups remain unvaccinated, disease will continue, health systems will remain under pressure, and the global recovery will be at risk. This is not theoretical. This is real. COVID-19 deaths have been increasing for the last 5 weeks, and several countries are reporting increasing trends in hospitalizations following waves of transmission driven by Omicron subvariants. Last week, WHO launched an update to the global COVID-19 vaccination strategy, emphasizing the need to vaccinate the most at-risk groups, including 100% of health and care workers, 100% of older people, and 100% of those at highest risk. We continue to urge all countries to strive for the target of 70% vaccination coverage with a focus on targeted vaccination strategies that prioritize the most vulnerable, which is the most effective way to save lives. While vaccines have saved countless lives, they have not substantially reduced transmission. So it's vital for governments and the private sector to continue collaborating and investing in the development of new vaccines that prevent both infection and disease. We also need vaccines that can be delivered more easily, such as through nasal sprays or drops. Crucially, it's essential as new vaccines and other COVID-19 tools are developed, they are available equitably to all countries. In addition to vaccination, WHO urges all countries to assess and strengthen their readiness and response plans for future waves of transmission, including surveillance, testing, strong clinical management, and a well-equipped health workforce. Tariq, back to you.
Thank you, Dr. Tedros. Before we go and start with questions, let me just introduce WHO officials who are online and who may also answer some of the questions if need is. We have Dr. Sosefal, who is Assistant Director General for Emergency response. Dr. Kate O'Brien is Director for Immunization, Vaccines and Biologicals. We have also Dr. Anna Maria Restrepo, who is lead on Research and Development Blueprint. With us is also Mr. Andy Seal, who is an advisor to the Director of WHO Department for Global HIV, Hepatitis and Sexually Transmitted Infections Program. We may have some other as well who may join at some point. With this, let's start with the first question, and that will be Shoko Koyama from NHK. Shoko, please unmute yourself and go ahead.
Hello, thank you for taking my question. On Saturday, the WHO issued a set of temporary recommendations in relation to the outbreak of monkeypox. But these recommendations are issued for state parties, and I couldn't quite get the recommendations for the general public. Could you elaborate the measures that the general public can take against infection? Thank you.
Thank you, Shoko. Dr. Rosamund Lewis will start.
Thank you for the question on what measures the general public can take to protect themselves against monkeypox and also to help reduce and stop the outbreak of monkeypox. So the most important thing is to appreciate one's own level of risk, to understand and to seek out information from reputable sources, from health agencies and from community organizations that are sharing correct information about how monkeypox transmits and about who's at risk. So the most important thing is to really seek out what are the choices that we can make that reduce our own level of risk. So at the moment, the people who are most at risk at this time are men who have sex with men in most countries in the world, not all countries, which is why it's also very important to pay attention to what's happening in your local region, in your city, in your country, in your area, and to reduce your own risk. This may include of course, sharing good information and also reducing the number of sexual partners, reducing the exposure in places that may put you at risk, such as crowded settings where lots of physical contact may take place among people who may be already at risk. There are a number of things that can be done to reduce one's own risk. If folks are going for a vaccine where it might be available, then it's important to understand that the vaccine takes several weeks to take effect and to generate an immune response, which means that someone who is being vaccinated against monkeypox also has to continue taking protective measures and making safer choices during the time after the vaccine has been administered. Thanks.
Thank you, Dr. Lewis. Let's go to next question. We have Kai Kupferschmidt from Science. Kai, please unmute yourself.
Thanks a lot, Tariq. Thanks for taking the question. Two really quick ones. It feels like this is the first time that you've, explicitly said that reducing the number of sexual contacts might be a good strategy at the moment to reduce the spread. I'm wondering whether you can elaborate a little bit on, how countries should handle this and what we can actually do to get the information out. And also, we do know from a lot of history that changing behavior, especially around, sex, is really difficult. And with the vaccine not becoming available very soon, it seems, I wonder, how long this can be kept up, even if people really want to do this.
Thanks, Kai. Do we have Mr. Andy Seal online who would maybe start with this? Andy, did you hear the question?
Yes, thank you, Kai, for the question. Hello to everybody. Perhaps I can start. It's a great question. I think there's a lot of learning from HIV, as you suggest in your question. I think it's one message within a package of prevention messages that needs to get through to people, and we need to take a lead from how communities are also handling the messaging here. So I think, for example, we've set up a community reference group that's already met 4 times, including representatives from all WHO regions. And they're also sharing with us strategies that are being led from communities. And this messaging around reduced partners is coming from the communities themselves. Clearly, this is, as you also suggest, potentially a short-term message. We hope that the outbreak, of course, will be short-lived. We hope that the other preventive measures in place will also support the outbreak to be contained quickly. I think the other messages that complement this are being very alert to symptoms, understanding what symptoms are that people should look for if they think that they have been at risk, and seeking medical advice rapidly should they identify the fact that they may have symptoms. So rapidly excluding themselves from sexual contact, close social contact in that case is probably one of the most critical messages as well. And we're also hearing from communities that really advice around support to obviously those who have been infected is critical. Really focusing on stigma and discrimination quite broadly as well will be critical in getting the outbreak under control. But I think the reduction of sexual partners is an important message for now. We're taking a lead from communities on how to message this. And we're also, if you heard when the DG spoke, he also recognized that where new partners are and where people do have new partners, make sure you've got the contact details so that follow-up can be organized should that be required, should somebody develop monkeypox. Thanks.
Thank you, Andy. I hope this answers the question. So we can go to the next one, and that's Helen Branswell from STAT. Helen?
Hi, thanks for taking my question, Mark. I want to switch gears to monkeypox, from monkeypox to Marburg. On Friday, WHO sent out a bond saying that all of the contacts of the 2 Marburg cases in Ghana had been through their 21 days of monitoring and none had developed symptoms. But we've since heard that there have been 2 additional cases, people who had been contacts of the first case. So I'm a bit confused about what's going on there. Can you please give us an update on what is going on in Ghana?
Thank you, Helen. We will go to Dr. Fahl. If he is with us. Dr. Fahl, could you please take this question?
Thank you, Tariq. Can you hear me?
Very well.
Thank you, Ellen. You are right. We have 2 additional cases of Marburg in Ghana. First one is the wife of the index case and the child of the index case as well. So this is information we received from the country. They have talked about 180 contacts followed up, but we still have additional contacts related to the last cases. There are more than 40. It means that all contacts were not out of the risk period. So the teams are working to investigate to understand better how these people were infected. Apparently, the child was infected by the mother, not by the index case. So that's why it's really important to continue making sure that, we have thorough investigation and making sure that, all contacts are followed up. This is extremely important because depending on the quality of the investigation, the ability to isolate contact, it will, be important to stop the transmission. And we are still having a challenge because the wife of the index case is still in a kind of prior camps, and the teams are working with the community to be able to isolate her. So the situation is still very difficult because we have 3 regions affected right now, although the number of cases is not high at the moment, but we need to make sure that every hotspot can be stopped. Otherwise, it will become more complex. So we are working very closely with the country, with partners to make sure that we can stop it as soon as possible. Thank you.
Many thanks, Dr. Fahl. And I understand that Dr. Anna Maria Restrepo may add something on the Marburg research for vaccines and therapeutics. Dr. Anna Restrepo.
Thank you, Tariq. We have been working with colleagues and researchers and developers for over a year now in a consortium called Marburg. As part of this research preparedness efforts, we have now identified all the candidate vaccines and candidate therapeutics for Marburg, and we have been working in close collaboration with the developers. In addition to that, in collaboration with the NIAID, the NIH, and many other research centers around the world, we are in the process of finalizing protocols for the evaluation of these vaccines and therapeutics. We anticipate that by the end of next week, we can have a protocol that could be presented to the national authorities in Ghana for consideration. We think that this is a good example of how research preparedness pays off, because before the outbreak, we already have the landscape of the medical contrameasures that could be used and the outlines of the protocols on how to evaluate, and a very good collaboration from the scientific community. So we are expecting to see what is the evolution of the outbreak, but we are ready to evaluate the vaccines and therapeutics if necessary. Thank you.
Thank you very much, Dr. Anna Maria. We'll go to next question. That's Max Kozlov from Nature. Max, can you hear us? Unmute yourself, please.
Hi, thanks for taking my question. Around a month ago, the DG supported changes to the naming of monkeypox or the different clades of monkeypox. And I was just wondering if there's any kind of movement on that, or what next steps might look like, and if it's too late now that there's been a public health emergency declared about it. Thank you.
Dr. Luis?
Sure, thank you. I'm sure you're aware that there are three different things. There's the name of the disease, the name of the virus, and the name of the clades. The name of the clades is something that scientists are already discussing through their research and in the scientific literature. Proposals are being made, such as naming clades 1 and 2, for example, instead of using geographic-based names. For the virus itself, the International Committee on the Taxonomy of Viruses has already embarked on conversations with their orthopox virus group on whether there will be any modifications to the not only the name of the monkeypox virus, but of course there are many other pox viruses that carry similar names that have been known for a long time. So that is up to the ICTV to provide a response to that. And for WHO, our responsibility is the naming of the disease, which has existed already in the International Classification of Diseases for some time. So there is a process that we have initiated, and welcome all proposals as to what the new name might be. Thank you.
Thank you, Dr. Luis. Dr. Swaminathan, would you like to add something?
Yes, just to add, I think, to what Rosamund was saying, that the naming of diseases, there was a revised procedure that WHO adopted several years ago, essentially to overcome the previous, history of naming diseases by named by place of origin or where it was first detected, or sometimes even a name of an individual, etc. So there are standard rules now on the naming of diseases, and there's a call that's been put out actually for suggestions, and then a committee will then consider those suggestions. So we, as far as I know, have not received any proposals for a name to replace monkeypox. So that process is still open, and as Rosamund said, we welcome any constructive suggestions. Thank you.
And just to add, while all this has been done, for the vast majority of people who deal with these diseases, experience them in the communities, the name per se is not a major issue. It's the weaponization of these names. It's the use of these names in the pejorative. It is the targeted manipulation of the implications of what these names make. The name in itself, the names in themselves, the people of Marburg today in Germany, the virus Marburg we're talking about now in Ghana is named after Marburg because it was first discovered in a lab there. All of those issues around geographic representation, but I don't think the people of Marburg today are worried about the stigma of that per se. But there are certain words and certain trigger words that are then used and manipulated in other circumstances. And they're basically frankly, racist connotations that come from some of this, and we have to call that out, because names are names, no matter what names we use. If people are determined to misuse and to weaponize names in order to isolate or discriminate or stigmatize people, then that will always continue. We will do, as Sumya said, and I think the international scientific community has a job of work to do to the extent possible to take those opportunities away. But that in itself is not the problem. The problem is the misuse of these terminologies around the world, especially when they implicate racial slurs.
Thank you. We will go to next question, and just to say that we got a question from Simon Martin from Radio France exactly on this. So I hope, Simon, you got the answer in previous interventions. Let's go to NBC, and we have Ben Ryan.
Hi, thanks for taking my question. As you know, there was a preprint that suggested that the R naught for monkeypox might only be over 1 for men having sex with men, meaning that risk group would possibly be the only one to have an average transmission of more than 1 person from each case. I was wondering if you could speak to that and just the overall, the quality of the risk for non-MSM, including women and children, you know, if there's any qualitative words you might want to apply to their risk at this time and looking forward.
Dr. Lewis.
Thank you, Mr. Ryan. So yes, you've indicated correctly that there's some suggestions, some modeling, and some publications are finding that R0 might be 1.6, 1.7, 1.8 in some European countries, where, as we have, as the Director General has already indicated, 99% of cases are still among men, and of those, over 95% to 98% are among men who have sex with men. So the R0 is a property of the transmission of the virus, and also the circumstances in which the virus might be transmitted, and it is a property when there's no intervention. So if there's no intervention in a circumstance where there's a lot of skin-to-skin contact, frequent contact on a regular basis, perhaps in the context of multiple partnerships or anonymous contact with anonymous partners, then that would be a circumstance without intervention where the virus can spread more easily. Monkeypox virus has been known in the past to have an R0 just under 1, which is why in the past the outbreaks have been self-contained, generally self-limited, and shorter chains of transmission. This may be changing now also because of the lack of global immunity to orthopox viruses in general, providing a larger pool of susceptible individuals who may, once exposed, may contract infection through lack of immunity. So I think the message that comes here is that they're important to continue to emphasize the choices that individuals can make to protect themselves. If the R0 remains less than 1 for most people, then the outbreak itself will be self-limited, so that's a very important feature. You did ask directly about risk for women, children, and others who may be exposed, so we know very clearly that one of the main modes of exposure for this particular illness is through direct contact, close contact, skin-to-skin contact, possibly even face-to-face contact exposure to droplets or virus that may be in the mouth. Many people have lesions in the mouth. And so that it's very important for anyone who has monkeypox to isolate so that they can protect also anyone else living in their household or anyone else that they may be in contact with. Household transmission is how this was first discovered. And household transmission is also may, in some circumstances, begin to occur now, and so it's critically important that everyone understand that this is a disease that transmits through close contact, and to make the choices that need to be made accordingly to protect themselves and other people.
Yeah, thanks. I just wanted to comment on the concept of the reproduction number, because we have such a educated public now, given the last couple of years that we've had for COVID-19. So Rosamund completely has provided an answer to that, but I just wanted to comment that this reproduction number is an average. It's the average number of someone who is infected can pass the virus to someone else in a susceptible population. It's an average, which means some people may have more than that and some people may have less than that. Any R0 above 1 means an epidemic can take off. And as you've pointed out, we have one particular population, communities of men having sex with men, where the R0 has been estimated to be over 1. That means the outbreak is expanding. And that means there's opportunities to bring that reproduction number below 1. And so all of the ways in which Rosamund and Andy have outlined, and the Director General has outlined, ways to reduce the risk, to reduce onward spread, because monkeypox is different than COVID. You need that direct physical skin-to-skin, mouth-to-skin contact, as has been described. There's many ways in which that risk can be reduced. So there is an opportunity to bring the R0, to bring that reproduction number below 1, in MSM communities with the right information, by empowering this community, activating this community to take control of the situation so that this outbreak of monkeypox in MSM right now can be brought under one.
Many thanks. Now we will move to AFP, Nina Larsen. Nina?
Yes. Hi. Thank you for taking my question. I wanted to ask about the two new peer-reviewed studies published in Science this week that claim that the animal market in Wuhan was really the epicenter of the COVID pandemic, and basically ruling out the lab leak theory. I'm wondering how credible you think these studies are, and if they will or should alter the approach to investigating the COVID origins. And I also just wanted to, I just had a clarification to ask about the previous answers. When talking about reducing sexual partners, I'm wondering, my understanding is that monkeypox is spread through close contact, but not necessarily sexual transmission. Could you just clarify if there is sexual transmission? Thank you.
Thank you. Let's start with the first question with Dr. Van Kerkhove.
Yes, thanks, Nina, for the question. So these two papers that have been published were actually available as preprints a few months ago. WHO, our internal secretariat, evaluated them, as did the SAGO, the Scientific Advisory Group for the Studies of the Origins of Novel Pathogens, evaluated these papers, as they have done with all of the papers that are currently available looking at how the COVID-19 pandemic began. So these are good analyses that have looked at all available data that is looking at the early cases, looking at where those cases occurred, the geographic distribution in space and in time, and looking at different exposures. There's another paper that looked at the genetic sequences that became available and looked at the potential for spillover events that occurred in that market. And then there was a third paper, which you didn't mention, but there's a third paper looking at environmental samples. So we, as WHO and the SAGO, were aware of this data as preprints and even before, because a lot of this was discussed and outlined in the March 2021 report of the WHO Joint Mission. And this gives further information about what happened early on in the pandemic in December of 2019, in early January 2020. It provides additional information that we have that is available. But for us, what is really critical and what critically remains is looking further within China, further within Wuhan and in the markets within Wuhan, about further serologic studies in the markets themselves, for example, among people who were exposed to animals that we know are susceptible to SARS-CoV-2 infection, to look at where the animals that were sold at those markets came from, so tracing back those animals to those source farms and looking to see what were the species that were sold, and if any specimens remain, to test those samples to see if there's any evidence of SARS-CoV-2 infection or antibodies, and then looking at the people that worked at those source farms. So for us, this does provide more information, around what was happening early days, but unfortunately, it's not enough. We need more studies to be done in China and elsewhere to really understand the earliest stages. So without those serologic studies in the markets, at the source farms, without tracing those animals back, it still leaves some open questions for us. But they're good pieces of work. We welcome more scientific studies, peer-reviewed scientific studies, to help us get closer to understanding how this pandemic began. And remember, the goal is not just to figure out how this pandemic began, it's to learn how we better prepare for the future. So that work will continue, because we will continue to have spillover events. We see this with even monkeypox. We see additional spillover that's happening in a number of countries. We see this with Marburg. We see this with a lot of pathogens with epidemic and pandemic potential. The goal is to learn. The goal is not to blame. The goal is to learn and to take those learnings to be better prepared. So the work of WHO continues. The work in countries for the studies that have been recommended by the SAGO continues. We, as the Secretariat, will continue to work with all countries to better understand and to further understand the start of this pandemic.
Just briefly to add that, like in all situations of origins, this is a scientific detective story that goes on, and each new piece of information adds to the overall assessment. And a new piece of information or new scientific studies can move more positively with one hypothesis or another. But like all stories like that, all hypotheses remain on the table until you can prove that one hypothesis is the explanatory hypothesis. And so it's important for us to remember that all hypotheses remain on the table, but we're very pleased to see this kind of work being done, which advances us and advances our common understanding of the origins of this disease.
Thank you, Dr. Ryan and Dr. Van Kerkhove. Mr. Seal, would you like to take this second question that was on the transmission mode?
Could you please remind me of the exact wording? Thank you, and I'll be happy to.
Now, if I remember correctly, the question that came, it was the transmission mode of monkeypox. Is it a sexually transmitted disease? Is it close contact transmission? So there's a need for clarification on that.
Thank you. So we have convened a number of STI experts to look into this question. And in short, they've concluded that this is clearly transmitted during sex. And so they're comfortable in describing this as sexually transmissible. But they have not yet felt able to reach a conclusion to, state that this is an STI. So they're looking at past experiences where there are multiple modes of transmission, including Zika, for example, and they're comparing different experiences from those types of experience. They're looking at lab data around presence in vaginal fluids and semen, of course, of the virus. In terms of messaging, I guess the one area where we might instinctively assume that we would be able to confidently say use condoms as a level of protection, we're not able to do that for monkeypox, just because we know that it's that close skin-to-skin contact that facilitates transmission, a little bit like herpes. Condoms aren't efficient in protecting herpes transmission, but other STIs, they are. So I think the critical piece is really focusing in on close, intimate, personal contact, prolonged contact that happens during sex as the key mode of transmission. And obviously, as others have said, we continue to interrogate the data. Thank you, Tarek.
Thanks very much, Andy. So yes, just Nina, just to come back to your original question and to confirm and of course endorse what Andy has said, but also to confirm what you suggested, which yes, it is close contact. There are other modes of transmission, not necessarily sexual transmission is required. So close contact of skin to skin, which is why health agencies are also sharing the information that while one group are predominantly affected and greatly affected at the moment, it is very important for all of us to understand, to appreciate that anyone can be at risk. It's a very difficult message to put across. There is one group that is primarily at risk at the moment, and this is the group that we really want to get information to on how to protect themselves. But at the same time, anyone who is exposed to monkeypox can also be exposed. So while the risk to the general public is at the moment not as great, it's important that we also share the message that it is possible to be exposed in a setting where there are many people together with physical contact, and that includes a household setting. So some people are being exposed in a household setting, both in countries where this disease has long been known, as well as now in newly affected countries.
Tarek?
Dr. Swaminathan, would you like to add something to this?
Just a very quick point on transmission. We've seen that in some countries, the Bavarian Nordic vaccine has been made available to some high-risk groups and also to those who've been exposed as a sort of post-exposure prophylaxis. I think it's important to remember that firstly, we don't have the full clinical effectiveness data on this vaccine, because the vaccines that we have today were developed for smallpox, and we believe that they would work against monkeypox, but those studies need to be done and the data needs to be collected. But also it takes time to develop an immune response, and the Jynneos vaccine, which is the Bavarian Nordic one that's been approved now in the EMA, FDA, and Canada, is a 2-dose vaccine. And it takes a couple of weeks after the second dose to really achieve full immunity. That's what the company says. And therefore, one is not protected a few days after taking the vaccine. So this is why, again, to highlight that the safe behavioral practices are really going to be very, very critical. And in fact, that's most important right now in reducing the transmission of this infection from person to person. The vaccine could be an add-on tool that might help, but at the moment, we don't have the data to confidently say that the vaccine is the best approach to this outbreak.
And just, I think Sumi makes a really important point, because it's a bit like with COVID. Dr. Tedros was saying from the very beginning of COVID, we need comprehensive, inclusive strategies that focus on all elements of this, on awareness, on diagnosis, on health-seeking behaviour, on risk reduction, on preventing onward transmission. And we're seeing benefits of that now in communities where we see open, transparent communication and good dialogue between governments and affected communities. We're beginning to see positive signs. So that idea of having, there's no silver bullets here, and we have to be very careful. Vaccines offer hope in every situation. But vaccines by themselves right now are not a silver bullet. This is not a situation where vaccines replace everything else. Vaccines will come into play in very specific situations and may become very important. Right now, there are uncertainties around that. There are issues around how long it takes to be protected when you're vaccinated, who should be vaccinated, what is the efficacy of these vaccines, what are the effective strategies. Is focusing on contacts or focusing on risk groups? There are unknowns here, and the scientific community is working extremely well. Dr. Tedros has had very high-level phone calls with other leaders of agencies like Gavi and CEPI and UNICEF to look at this at the highest level, to see how best we move forward strategically. And there is great hope in that. And Sumia, you've also said that we need short, medium and long-term strategies here for these vaccines, because there's an endemic situation with monkeypox as well. So dealing with this outbreak alone, we need to deal with the long-term issues of countries that have been affected for decades by this disease. So taking a comprehensive, long-term approach to this, with identifying what we can do now to bring vaccines into play as part of a comprehensive strategy has to be our way forward. And again, because of these uncertainties around what we don't know, it's really important we collect data along the way. This is one of these situations we're collecting randomized evidence where we can to ensure that we fully understand how efficacious these vaccines are and what strategies will give us the best outcomes for the populations that we're serving.
Thank you all. We have a number of questions, and I'm afraid we probably will not be able to answer all of them, but let's take one or two more. We have Omar Yildiz from Anadolu News Agency. Omar, please unmute yourself.
Hi, thanks for taking my question. My question is about vaccinations, actually, and actually Dr. Ryan told us about the special circumstances. So my point is, given the current rise in the cases, when actually can we expect a mass vaccination campaign in international level? Thank you.
Dr. Lewis, please.
Thank you very much. The WHO guidance, interim guidance, has been it is online. It's been online since the 14th of June, I believe, and it clearly states, as Dr. Tedros also stated this afternoon, that mass vaccination is not recommended at this time. This is a virus which is at the moment affecting a specific group of people, and there are behavioral interventions that are effective, and vaccine may also be effective based on prior experience, but we don't have effectiveness data for monkeypox in this type of outbreak at this time. So we are strongly encouraging all countries and all parties to undertake studies to collect data on effectiveness and safety of this vaccine, even as they're rolling it out, where it can be rolled out for persons who are contacts who may have been exposed or for persons who may be at high risk for different reasons. At this time, there's no indication of a need for mass vaccination, of course, we remain open to how this outbreak will evolve. We hope it will not evolve. We hope we are still able to stop this outbreak through the combination of measures that are available: surveillance, contact tracing, isolation of cases, monitoring of contacts who need to monitor themselves for fever or development of other symptoms such as a rash, risk communication, community engagement, particularly engaging with associations and individuals who are themselves at high risk at the moment, seeking out support from community leaders and influencers, and of course the entire package of interventions that has been outlined in the temporary recommendations that the Director General has issued on Saturday for all member states and all stakeholders in responding to this outbreak.
Thank you, Dr. Lewis. Let's try to take Sarah Jerving from DEVEX. Sarah, please unmute yourself.
Thank you so much. Today, MedAccess and the Clinton Global Health Initiative announced that they negotiated a price of $1 per HIV self-test. Do you think that price is low enough to increase access broadly enough? Thank you.
Thank you. Andy, would you like to try to answer this question?
Thank you, Tarek, and thank you for the question, Sarah. I'm actually in Montreal at the moment at the International AIDS Conference, and that announcement was being made in the context of the conference. I have colleagues involved literally now in that conference who could be better placed to answer your questions. So, in short, we are very happy with this reduction, and we see this as a positive way forward, and we're promoting it appropriately through our websites. Of course, communities and others will have their own perspectives, and we work in collaboration always, including with manufacturers, to achieve the best ways forward to get optimal access. Thanks.
Thank you, Andy, very much for this. So let's try to take as many questions as we can. So let's try with the Wall Street Journal. We have Denise Roland with us. Denise?
Hi, thanks for taking my question. I've got two on monkeypox. One is, in this narrower group of people who should be targeted for vaccination, this high-risk group for exposure, what's your best estimate for the number of people in that group? In other words, how many doses does the world need to vaccinate all the people at high risk of exposure in this sort of narrower way, short of a mass vaccination campaign? And secondly, is any action underway to expand the manufacture of MVA-BN, either by speeding up the fill and finish of bulk or making more bulk vaccine? Thank you.
Thank you. Let's go to Mr. Tim Nguyen. Tim.
Thank you, Denise. WHO has currently activated our infectious disease modeling network to look exactly at these questions about the global need to serve different intervention strategies, including different forms of vaccination strategies. So as we are looking and gearing towards the results of these experts' consultation, we do some ballpark estimation on some of these needs to help guide us with our next steps in our planning process. So if you look at a post-exposure vaccination strategy, basically what we kindly do is extrapolating the number of global cases and multiply by 10 to 20 contexts each of these cases have. So in this context, we are looking right now of 18,000 cases, so this translates into 180,000 to 360,000 vaccine doses for such a strategy. When you're looking at pre-exposure prophylaxis, and depending on what countries define as high-risk groups, including MSM population with high-risk behavior, this could account to currently for the 78 countries that are reporting cases to something between 5 to 10 million doses of vaccine. So these are very preliminary ballpark estimation, and we're looking further to the modeling studies that we have been commissioning. Now, when it comes to the supply situation, with that later strategy, we know at the moment, if we do this nowcasting, there is not enough vaccine in fill and finish form to serve such a strategy in the current context. So the key, and I think that's what your question has been gearing up, how fast, can the turn of bulk into fill and finish happen? And this is where we are in constant discussion with manufacturers on expanding or what are their plans in terms of fill and finish capacity. Our understanding, this is now gearing up. On the manufacturing side. Here in WHO, we have received offers from different manufacturers to support that fill and finish capacity, and that's based on the WHO and the DG call for those intensified action to happen after the declaration of the public health emergency of international concern. So this is where we're trying to match those offers that are coming in and providing these offers also to the current manufacturing capacity. Thank you.
Dr. Swaminathan, would you like to add?
So very quickly, I think Tim has covered most of it, but we are in discussions with the manufacturers to do a couple of things. The first one is to get an idea of the availability of doses, the finished ones that can be used immediately. Many of them have been committed to countries already, as countries are purchasing these doses from the companies. So we would also like to explore the possibility of donation from the countries that have already booked or purchased doses so that they could be put into a stockpile for countries that do not have currently any access to vaccines, and also for research use, because as I said earlier, there is a need to generate data. And then the second one we're exploring is on the fill and finish, because companies have, Bavarian Nordic has bulk, and it would be maybe possible to get some other companies to support them in the fill and finish process. And then the third is the longer term needs, particularly for the countries where where monkeypox has been spreading for the last several decades, where a vaccination strategy again is being thought about. Again, it needs more thinking, it needs more data, it needs more research, it needs better surveillance. But in the case that such a vaccine may be used in the population, we will need then to think about technology transfer, manufacturing on a wider scale. And this is where, again, the whole initiative of technology transfer, of distributed manufacturing, of enabling local manufacturers to produce vaccines for endemic diseases, and also bringing the cost down to make it more affordable and accessible. I think this is a test, again, for some of the lessons we learned from COVID. Monkeypox right now, luckily, is not killing people, but we don't know. We have to prepare for the future for this and other pathogens. And this is where we have an opportunity now to look at how R&D and manufacturing, particularly for these pathogens which can cause sudden epidemics and pandemics, how does the world actually work together to address a situation where there is shortage, limited supplies, and the demand may actually outstrip the supplies very quickly. Thank you.
Thank you, Dr. Swaminathan. Let's move on. We have Erin Prater from Fortune. Erin, can you please unmute yourself?
Yes, thank you so much for taking my question. Just curious if there's been any kind of update in the evolution of the monkeypox virus. I believe several weeks ago, CDC officials said that at least 2 different strains of the West African clade had been identified in the US. Any update on that? Thank you.
Who would like, maybe Dr. Lewis can start?
Sure. So indeed, there are a couple of studies coming out now. There was another one this week. These are very early days yet for these types of studies. The clades of the viruses, as you know, go back many years, go back 70 years. And then the West African clade, or clade 2, has always been there, but has appeared more frequently since 2017. But there are extended gaps both in the time frames during which sequencing was done, as well as there are many perhaps sequences there that are not yet available. We clearly see that there has been some evolution, but we don't yet know what it means in terms of transmissibility. We don't yet know what it means in terms of how the disease manifests when someone is infected with the virus. However, what we can certainly say is that the longer the virus continues to circulate, the more opportunity it does have to continue to be modified or to mutate. Because as long as it continues to spread, it will have further opportunities to adapt to the human population.
And just maybe to build on that point and the point that Sami made, we do have to break this cycle of having these reactive approaches to the emergence of these diseases in new populations. Many people, Rosamund and many others work in WHO and in many scientific institutions around the world, and they work on these diseases, you know, over decades, and they maintain a body of knowledge, and they struggle to get research money, they struggle to get the necessary resources. Manufacturers have big costs in developing these niche products because they have to go through the whole process for what is a product that may not have a big market. So there are real deficits in how we're looking at this, in terms of scanning the horizon and seeing the risks coming before it comes over the hill. Now we're reacting when the problem is amongst us and causing major problems. And then that's when we end up having to scramble collectively, scramble scientifically, scramble from a manufacturing point of view, scramble from a communications point of view. We need to stop scrambling so much. We need to be in a much stronger position with pox viruses, flu viruses, coronaviruses, filoviruses. Some of you will be repeating our pathogen prioritization process in the coming months. We need to take this seriously. When we sit together as a global community and we prioritize pathogens for the future, that's not just about waving a flag. That's about investing upfront in the science, in the research, in building countermeasures. It will cost money, and it does cost money. But it is a fantastic investment in protecting us down the line. And $1 spent in preparedness is worth $1,000 spent on response. And I think we need to really take a much more systematic look at how we prioritize pathogens for the future and then how we invest. So when these things come along, we're not having to deal with limited availability of diagnostics, limited availability of antivirals, limited availability of vaccines, because this will just repeat, and we will live, die, repeat on this unless we take control. And I believe we have, for the first time in human history, the science and the cohesion, I hope, to take these things more seriously, more systematically, and we need decades of run-up to many of these diseases in order to have the necessary countermeasures in place. So, and Tedros has called for this in pandemic preparedness and response, to really get the focus back on preparing, on being ready. Yes, continuing to respond well, but continuing to respond well to these events, making up for gaps that exist, systematic gaps and weaknesses in our health system, systematic gaps in our diagnostics, systematic gaps in our manufacturing capacity, systematic gaps in our fairness and equity. These will just continue to repeat themselves. So I do think as we sit today with COVID, with monkeypox, with Marburg, with polio, we need to realise that this is not stopping, and we need to be much more considered, measured and strategic in our approach. And this is what Tedros has been calling for. He's been calling for this for a very long time, long before COVID came, and it's time for us all to be much more directed and systematic in how we deal with these diseases.
Thank you, Dr. Ryan. So maybe we'll take one last question. We are already beyond the hour, and there are still many questions, but I will invite all those whose questions we didn't have the time to answer to come to media team, and we will try to answer each one of them. So let's go to Gabriela Sotomayor from Processo for the last question today. Gabriela.
Hola, thank you. Thank you very much for taking my question. So what are your main concerns regarding monkeypox in children? I understand that the disease can be very serious for them. And then a question for Dr. Tedros. What do you recommend to countries from Latin America, for example, like Mexico, with few cases? The outbreak is being underestimated, which is not even remotely like COVID. There is no comparison, but Mexico is one of the countries with the highest number of deaths because they did not take COVID seriously. So what is Dr. Tedros' recommendation in this case, these countries? Thank you.
Thank you, Gabriela. We will try to answer the question about children first. Dr. Lewis.
Thank you, Gabriela. What we've known from monkeypox research in the past is that children are at higher risk of severe disease. That does not mean that every child that contracts monkeypox virus infection will develop severe disease. There is, of course, a range of clinical manifestations like there are with most infectious diseases. However, it does mean that there is a preponderance of children, pregnant women, and immune-compromised persons amongst those who do develop severe disease. So a child can develop, for example, if the rash is very extensive, there can be fluid loss, the child can become dehydrated. Also, you know that the lymph nodes predominantly, often in both the classic and the current forms that we're seeing, appear on the neck, and these lymph nodes can become significantly enlarged and make it difficult to swallow, which also can contribute to dehydration. There can be severe pain in the mouth and throat, which contributes to difficulty eating. So nutritional status, maintaining hydration, nutritional status is really critically important for children who do become quite ill. Taking care of the rash is important for children who develop significant rash. And of course, monkeypox can also affect the other mucosal surfaces, especially and including the eyes. And certainly in the African setting, we've seen a number of people who develop scarring over the cornea, become blind due to monkeypox because of the lesions that appear in the eyes and on the cornea. So there are a number of other things that can happen. We're starting to see a few cases of encephalitis, which is inflammation of the brain. This has been reported in the past. And so we want to do everything we can to keep everyone safe, of course. But if a young child or a pregnant woman may also have consequences that are through having the virus during pregnancy. So these are people who are vulnerable, either because of their particular, their age, their status. They may have, others may have immune compromise, and children are still building their immunity, and others may have their immunity compromised, whether through pregnancy, whether through untreated HIV, whether through chemotherapy, whether through other immunosuppressive treatments. So these are some of the things that we look for, and these are some of the things that we want to guard against and protect vulnerable people during this outbreak. Over to you, Mike.
Dr. Ryan.
Just briefly, Alan, you're correct. This is not COVID. Monkeypox is not COVID, but it is still a serious event that requires scaled up and intensified action because we don't know the future. And there are enough uncertainties here. And this is deeply affecting one very important part of our community as well. And we need to show that solidarity. We'd expect it to be shown to all parts of our community. So this is, and Dr. Tedros has called on this. We've maintained under Dr. Tedros' leadership activities on monkeypox and smallpox right the way through COVID, through the leadership of people like Rosamond here, keeping scientific committees working, keeping the research community moving on this process. Secondly, when Dr. Tedros called the committee together for the first time, he was reaching out and alerting the world that this is a problem, it's on the table, and we're looking at it closely. Bringing the committee back together again, and then issuing his declaration of a fake is a call to action, and it is a call specifically to action by member states all over the world. With the specific reference to Mexico, many countries have had the good and the bad of COVID. No country can stand up and say we've been perfect. No country is in a situation where it did everything terribly. We all struggled collectively to meet the challenge that COVID has brought to our communities. So from that perspective, I think Dr. Tedros is saying to every country, including Mexico, monkeypox is an issue. It requires intensified, coordinated response. It requires us to beef up diagnostics, surveillance, communication, and most importantly, open, transparent, sensitive communications with all parts of our community. This is the way for this disease to be contained and controlled. That needs to happen everywhere, in every country, including Mexico.
Thank you very much, Dr. Lewis and Dr. Ryan, for answering this last question for today. We will send audio and video files of this press briefing later in the evening, and hopefully transcript will be available tomorrow. With this, I will give the floor to Dr. Tedros for his closing remarks.
Thank you, Tariq, and I would like to thank all colleagues from the press who have joined today, and see you next time.